Okay. Good morning, all. The topic for today is child abuse and birth injuries. So I am presenting the part birth injuries part, and by definition, birth injuries means an impairment of the infant's body function or structure due to adverse influence that occur at birth, and it can be either avoidable or an unavoidable event which occur. And it is seen that 2 to 3% of per thousand live birth, the incidence of birth injuries are 2 to 3% in thousand live births. And as we can expect, it is more common in vaginal deliveries compared to the cesarean deliveries. So if we consider the risk factors includes primiparity, small maternal stature, maternal pelvic anomalies, prolonged or unusual rapid labor, oligohydramnios, malpresentation of the fetus, and major factor which is mid forceps or vacuum delivery, version and extraction, and very low birth weight babies can also have birth injuries, and fetal macrosomia, fetal anomalies, and maternal obesity. So if we see like in cases like macrosomia, there is that if the weight of the baby, if it increases from 4 or greater than 4, that is if it is 4.5 or greater, the chances of birth injuries also increases twofold. And if the weight of the baby is greater than 5 kg, it is said that it is 4.5 times the risk. There is risk for birth injury. And among these factors, the mid forceps or vacuum extraction are the major risk factors which are responsible for birth injuries. Now some specific birth injuries which are associated with the risk factors are like in forceps delivery, the facial nerve getting injured, and in vacuum extraction, it is associated with depressed skull fracture, caput succedaneum, and subgleal hemorrhages. And in forceps or vacuum delivery, there are cephalohematoma, retinal hemorrhages, shoulder dystocia, intracranial hemorrhage. And in Breif's presentation, there is brachial plexus injury as such, and intracranial hemorrhage, gluteal lacerations as the presenting part is, and long bone fractures. And macrosomia, it's, as we know, is mainly associated with shoulder dystocia, and clavicle and rib fracture can also occur. And abnormal presentations like face, brow, transverse, or combo, it's mainly associated with excessive bruising, retinal hemorrhages, and lacerations. Now, precipitous labor delivery would result in bruising, intracranial and extracranial hemorrhages. And if we see the frequency of birth trauma and related to the mode of delivery, as we can see, the forceps delivery is one of the major factor which can cause birth injuries, and among them, it is mainly associated with intracranial or intracranial or extracranial hemorrhages, and facial nerve injury, and also brachial plexus injury. And the other factors like which comes after that are vacuum assisted delivery and spontaneous birth. So among risk factors, cesarean delivery is also it is also a matter of debate. Like in some definition, it says that cesarean delivery does not decrease the risk of birth injury. Now, classification of birth injuries. Classification of birth injuries include soft tissue injuries, head and neck injuries, cranial nerve, spinal cord, and peripheral nerve injuries, fractures, and intra-abdominal injuries. So, soft tissue injuries are very common, and it includes abrasion, erythema, ecchymosis, and lacerations. And if we see this erythema and ecchymosis and all are transient, and they usually it's mainly seen with forceps delivery, and it mainly presents in the presenting part during delivery. And if we come to and we should also rule out some other coagulation disorders before coming in before if you're considering ecchymosis and petechiae. Now, laceration and abrasion, it can be also due to the secondary to the scalp electrodes we place, and also the fetal scalp blood sampling or injury during birth, and it can be also during birth. And fetal laceration has been reported as the most common birth injury, which is associated with cesarean delivery. Now, this subcutaneous fat necrosis is entity which occurs. It is due to due to stretching during birth. There can be ischemia to the adipose tissue, which is often just adjacent to the bony structure, and it usually present within the first 2 weeks after the first 2 weeks of delivery, and it is a sharply demarcated, irregularly shaped, non-pitting subcutaneous plaques or nodules, and this can undergo calcification later. So this babies need to be followed up for at least for 6 to 7 weeks, because they also can have features of hypercalcemia. Now, extracranial injuries. Extracranial injuries, as we know, it's very common. That is caput subterraneum and the cephalometoma, and subglial hemorrhages. And if we compare caput subterraneum and cephalometoma, caput subterraneum is something which is which is evident at the time of birth, and it usually is soft pits, pits on pressure, and it can cross a suture line, and it is not well defined. So the its size is largest at birth, and it usually subsides as the gestation is progresses, and there will be no underlying skull bone fracture associated with it, and usually it's managed conservatively. At the same time, cephalometoma appears within a few days after the birth, and it's most commonly associated with forceps delivery. At the same time, a caput subterraneum is more associated with the vacuum delivery, and it doesn't cross the suture line, and as a result, it is soft, elastic, but does not pitch on pressure. And initially at birth, it may not be evident. After a few days of birth, it appears, and it disappears by 6 to 8 weeks of birth, and there is no treatment required, but sometimes it can precipitate hyperbilirubinemia later. Now, subglial hemorrhage is hemorrhage under the aponeurosis of the scalp, and it is due to the damage due to when there is scalp traction, which occurs in case of vacuum delivery or other normal vaginal delivery. Also, this result in emissary vein getting injured and resulting in hemorrhage. So we have even a 1 centimeter increase in the depth of subglial space, it can hold up to 260 ml of blood. So we should be constantly looking for the head circumference, that is 40 ml blood loss for every 1 centimeter increase in the occipital circumference should be considered. And so we should also the child can land up in rapidly progress to pallor and shock. So we should monitor urinary output and signs of shock, and monitor serial hematocrit and evaluate coagulopathy, and we should transfuse BRBC if needed. Now, the intracranial hemorrhages are very rare while considering birth injuries. It mostly increases with operative deliveries, like operative vaginal deliveries, that is vacuum or for forceps delivery, and this other stats, that is it is associated majorly with forceps delivery, that is 17 per 10,000 forceps deliveries. ETH is epidural hemorrhage is mostly usually accompanies a linear skull fracture, and the major source for it is arterial source, It is usually managed conservatively, but surgical management may be required if there is large hematomas, that is greater than 1 centimeter thickness and 4 centimeter long hematomas. And depressed skull fractures, hydrocephalus, or shifting of the brain parenchyma are also, in these conditions also we may require surgical management. In subdural hemorrhages, the subdural hemorrhages form between dura mater and the arachnoid mater, and symptomatic infants usually present within 24 to 48 hours of life. And the main symptoms they present with may be seizures, respiratory distress, apnea. And for if we consider the diagnostic in emergent situations would be a CT scan, and usually conservative management would do, as it is due because of the plasticity of the neonatal skull. But emergent surgical evacuations are needed in case of features of raised ICP, and in case of posterior fossa bleed, as the posterior fossa lacks this plasticity. And serial hematocrit monitoring should be done in view of shock. And now next is facial injuries. Among facial injuries, nasal septal dislocations are very common, and so we can see the asymmetry of the nares and flattening of the side of dislocation. And if we see for the usually it need a early management, that is within 3 days, or delay in treatment greater than 3 days would result in nasal septal deformity, and it is usually reduction is done in case of within 3 days. In ocular and other injuries which can occur in facial injuries are ocular injuries. The ocular injuries it can be divided as minor and major. The minor are very common to see, like retinal and subconjunctival hemorrhages with forceps delivery and lid edema. Major ocular injuries are very uncommon, and it includes hyphema, the vitreous hemorrhage, lacrimal duct or gland injury, disruption of Descemet's membrane of the cornea, retinal hemorrhages up to which can with up to 1 to 5 days, and subconjunctival hemorrhages up to 1 to 2 weeks. Skull fractures. Among skull fractures, the depressed skull fractures are very common, and it is due to invert buckling of the skull bones, and it is mainly associated with forceps delivery. A head MRI is to be done in case there are features of intracranial injury or intracranial hemorrhage is suspected. A depression greater than 1 centimeter often requires surgical intervention, otherwise it can be managed conservatively. Abdominal injuries are very uncommon in case of birth injuries. Among them, the liver hematoma, which is the most common which can occur, and it usually presents with poor feeding, pallor, tachypnea, tachycardia, jaundice, which develops within the first 1 to 3 days of life, and there will be dislocation of abdominal wall and circulatory collapse with shock. The management is restoration of blood volume and correction of coagulation disturbance, and surgical consideration. Laparotomy would be needed in if the condition worsens. And adrenal hemorrhages can also occur, and it is very unlikely, but it usually occurs unilateral, and 75% occurs in the right side. And it in main presentation would be fever, flank mass, purpura, and pallor. It can be managed with blood volume replacement and steroid therapy. Splenic hematoma is usually mainly seen in children who have added splenomegaly, and also it is seen in children with macrosomia, and also in case of breech delivery. So clinically a mass will be palpable in the left upper quadrant, and the X-ray would show a stomach bubble displacement medially. So now coming to fractures. Among fractures, clavicular fracture is the most common fracture which can occur, and it occurs usually in 2% of the cases among 1,000 deliveries, and a callus if it is not a complete fracture, a callus formation at 7 to 10 days of life, 10 days of age, would show a green stick fracture, which could have occurred. And in case of a complete fracture, we could feel crepitus, palpable bone irregularities, and spasm of the sternocleidomastoid muscle. And usually we go with the conservative management with long sleeve garments, which is pinned to the chest with elbow at 90-degree of flexion. The next is humerus fracture. Even though rare, it is the most common long bone fracture which can occur, and it usually occurs in the proximal third of the humerus and are transverse and complete. Splinting for 2 weeks is required, and followingly the femoral fracture. It is mainly associated with the risk factors like congenital hypotonia, breech delivery, and cesarean section. The most common among them is the spiral fracture, which can occur. The management is usually with the Pavlik harness cast or hip spica cast, which is applied for 2 weeks. Dislocations are very uncommon, and it is usually misdiagnosed with epiphysis, that is Salter Arrest type 1 fracture, that is slipping of epiphysis plate from the metaphysis. And to distinguish it, usually the plain radiographs are not satisfactory, as there is lack of ossification centers in neonates. And so ultrasound and magnetic MRI may be required in case of to identify this. Now, one of the main topic, that is neurological injuries which can occur following birth injuries, are among them the brachial plexus injury, the phrenic nerve injury, the facial nerve injury, laryngeal nerve injury, and spinal cord injury. So the brachial plexus injury, it is very common, and it is almost present in 1.5 per 10,000 live births. And the risk factors for this are macrosomia, shoulder dystocia, instrumental deliveries, and malpresentation. And this is a classification by NARAC, classification of obstructive brachial plexus injury. This majorly looks at the outcome, how will be the outcome of the various injury. We will come back to it. The Erb's palsy Erb's palsy is one of the most common brachial plexus injury which can occur, and which mainly affect the upper trunk, that is at the level of C5, C6, and occasionally the C7 level. And most common type, and it occurs almost 90% of brachial plexus injury, it's at the Erb's point. So the mechanism is almost common for all brachial plexus injury, and it is a result from the lateral flexion of the head towards the contralateral shoulder with depression of the ipsilateral shoulder, producing a traction in the plexus. So most of the brachial plexus injury, as a result, is also associated with phrenic nerve injury. And in Erb's palsy, we can see there is the arm is adducted and internally rotated at the shoulder level, and there is extension and pronation of the elbow and flexion of the wrist and fingers, which is classically called the waiter's tip hand. And in total brachial plexus injury, it accounts for 10% of the cases in which the entire arm is flaccid, and all reflexes, including the grasp and sensation, are absent. At the same time, in Erb's palsy, the grasp reflex will be preserved. At the same and other reflexes like the biceps and Moro's reflex will be absent in case of Erb's palsy. And Klumpke's palsy is very less common, and it is due to the injury at the level of C7, C8, and T1. And less than 1% of the brachial plexus injury accounts result in Klumpke's palsy. And the Moro's reflex will be absent, but biceps reflex will be present in case of Klumpke's palsy. And it can be associated with Horner syndrome due to the involvement of T1 segment. And intrinsic muscles of the hand and the long flexors of the wrist and fingers are also involved. The management is almost same for all brachial plexus injuries, and is usually clinical improvement in the first weeks after birth indicates normal function while will return. And the therapeutic methods include stretching and sprinting and targeted strengthening. Objective score, the University by University of Toronto score has it predicts the ability in selected babies of for surgery at 3 months of age. Now, phrenic nerve injury occurs due to the lateral hyperextension of the neck at birth, leading to injury at C3, C4, and C5 levels. 75% of the patients have associated brachial plexus injury also, and it mainly present with respiratory distress and cyanosis. The chest radiograph may show the elevation of the affected diaphragm, and the initial management is usually supportive, and the child may require mechanical ventilation, and diaphragmatic plication is considered in refractory cases. Now, if we the spinal cord injuries, they are also very rare, and it is associated. It's more majorly seen in vaginal injury, vaginal delivery of an infant with hyperextended head or neck, and or in case of breech delivery, and it can also be seen in case of severe dystocia in case of microsomia. And less than 0. It is very uncommon, and it's only seen in less than 0.2% in 10,000 live births. The prognosis depends majorly on the severity and location of the injury. So, cervical spine radiographs and CT scan and MRI may be helpful in the diagnosis. Now, last is the sternocleidomastoid mastoid injury, or it usually present as muscular torticollis or congenital torticollis, in which the muscle is hyperextended and ruptured, and hematoma formation and the subsequent fibrosis would occur. So it's usually diagnosed by ultrasound. Fusiform enlargement and heterogeneous echogenicity is seen at the sternocleidomastoid, and X-ray should be done to rule out other abnormalities of the skull spine. And initially, we can do a conservative management with the stretching of the involved muscle. Surgery is needed in torticollis if torticollis persists after 6 months of physiotherapy, and sternocleidomastoid release surgery is performed.
Good morning, everyone. Today I'll be talking about the topic child abuse. Child abuse can be mainly categorized into a form of physical abuse, sexual abuse, emotional or neglect. And it is said that children usually become the victims either through the action or through the lack of action by their parents, which results in subsequent abuse or neglect. Introduction to child abuse. Basically, the minor status of children leads to the issue of the relative rights that the parents or the guardians of the children get. And it is seen that not all of the parents are willing or capable of basing their decisions on the interests of the child, and this may subsequently result in abuse. All the instances of abuse are to be reported, and the reported individual is protected from any liability, and there is penalty for failure to report any case of child abuse. Coming to the risk factors of abuse, it may be either the caregiver or the parent, the child themselves, the family dynamics in which the child is grown up, or the surrounding environment. It is seen that 80% of the abusers are the parents themselves or the caregivers, and it is seen that 30% of the abuse victims end up abusing their own children. They are seen to have poor self-esteem and poor impulse control. They may have substance abuse problems. They may be younger parents, and they, again, as mentioned previously, they themselves must have been victims of abuse. It is seen that younger children who are usually unable to defend themselves end up being the victims of abuse. The child may be in a learning phase and may not be able to respond positively to any expectations by the parent or the caregiver. And the children who are the victims of the abuse may end up growing up to experience higher rates of depression or substance abuse. The major risk factors are the age of the child, which is less than 3 years, a child with a cognitive disability, physical disability, emotional disability, and it is seen that preterm low birth weight children are also more prone to sustaining child abuse. The family dynamics may include growing up in a single parent household or a large family, or any history of domestic violence in the family. The environment may be an environment that is poverty stricken. There may be features of unemployment, there may be lack of education, it may be a high crime area, and there will be lack of accessibility to any medical facilities or any social services for the child. Coming to the presentation of children with child abuse, it is seen that the children who are abused are usually withdrawn on initial interaction, and they usually avoid any eye contact. They respond with answers which they think that will please the interviewer, and the history of the injuries will be unwitnessed sometimes. And on further questioning, they may be changed in the history that is on recollection, and the injuries may not be consistent with the history provided by the child. They may have presentation with multiple injuries that may be in different stages of healing. And there are some specific physical signs in younger victims which have to be raised as a red flag sign for child abuse, which include bruising on the body, the fractures of long bones, retinal hemorrhages, any burns that are of patterned type, or perineal trauma. On questioning the history, there might be an abnormal family situation. There may be some unrelated caregivers for these children, history of substance abuse, and even history of past abuse in the family. Yeah, there are some signs and symptoms which have to be considered when a child is presenting with a suspected child abuse or neglect. The child may present with a subnormal growth, that is, the weight, the height, or both will be less than 5th percentile. The velocity of growth will be slower. There may be head injuries. The frenulum of the lip may be torn. There may be unexplained dental injuries. The child will have bilateral bruising around the eyes, but it will be a history of a single fall or a single blow. There may be abnormally noticed hair loss, retinal hemorrhages, or diffuse nervous system injury, but again with a history of a very minor fall. The child may present with injuries to the skin. There may be bruises or burns which are specifically shaped like an object. The child may present with bite marks, or the burns may present with a glove or stocking appearance as seen in this diagram. That will be suggestive of an immersion injury. The child has been immersed in some fluid that is hot, and the bruises on the body may present in various colors, suggesting that they will have occurred at different stages of healing and it's not from the same injury. And the child may present with injuries to soft tissue areas which are normally protected by the clothes, such as the thighs, the stomach, or the upper arm. The child will present with gastrointestinal or genitourinary injuries. Even child presenting with bilious vomiting, recurrent vomiting or diarrhea that is only witnessed by the parent, or any chronic pain that is to the abdomen or the perineum with no identifiable cause, any history of genital pain or rectal pain, any visible injury to the genitals or the rectum, and any child presenting with a sexually transmitted disease. The child may present with bony injuries such as rib fractures, but again in the absence of any major trauma, such as a motor vehicle accident. The child may have a very complex skull fracture, again from a very small fall. There may be long bone fracture in an infant, or any femoral fracture in any child less than 1 year of age, and again multiple fractures in any various stages of healing, or any inconsistent laboratory results, abnormally visualized sepsis or electrolyte disturbances that are inconsistent with the child's state, and any positive toxicological test in the absence of any known history of ingestion of any substance. And if on CSF analysis, it may be a xanthochromic analysis in an infant with the altered mental state in examination, but on history they are not giving any history of trauma. These are all suspicious. Coming to the different types of injuries that are seen in patients of child abuse, the most common injury associated with child abuse is head injury. Also, it is the most common cause of mortality. Mostly, they may present with a feature of shaken baby syndrome or a shaken impact syndrome, in which the baby is shaken in the hands violently. That may lead to acceleration and deceleration of the brain. This leads to injuries such as diffuse axonal injury, tearing of the bridging veins, subdural veins, and can lead to subdural hematoma. These children may also have external bruising on the chest, shoulder, and neck, suggested that the child has been grabbed at this position and shaken violently. Retinal hemorrhages in these patients are very pathognomic of child abuse, because it is very unlikely in it is a very rare presentation in non-injury injury such as birth injury, and any child presenting with retinal hemorrhages has to be evaluated for any suspected child abuse. The other presentations with head injury can be either a blunt trauma, or the patient can present with a secondary injuries to the brain because of the injury. Blunt trauma will be with contact with objects that can lead to multiple fractures as well. They may be repetitive injuries, but in children, it is seen, in younger children, it is seen that external signs of trauma are quite infrequent. They may only present with the internal injuries, but in older age groups, external signs of trauma are also seen with the internal injuries. Secondary brain injuries on presentation can be anoxia, apnea, the child may have hypoperfusion, there may be cardiac arrest, even herniation of the brainstem in these patients. Coming to the next presentation, fractures, it is seen that 80% of the cases are identified on radiographic imaging, and in young children, mostly it is intentional trauma that causes fracture. It is less likely that there is unintentional trauma that can cause fracture, because they need a large amount of force to produce this kind of injury that are seen. So any long bone fracture in a child less than 2 years has to have a high index of suspicion, and always the mode of injury is to be confirmed by the history of presentation and how exactly the child sustained the injury. The types of fractures in presentation may either be a spiral fracture or a single transverse fracture. Previously, spiral fractures were actually the most commonly presenting fracture in child abuse, but now it is single transverse fracture. In spiral fracture, it is by rotation of the extremity that causes torsion, resulting in subsequent fracture that is along the bone. And single transverse fracture is a direct bone injury at the site of impact, and that is the currently most commonly seen type of fracture in child abuse. Then it can be diaphyseal fractures, that is actually the most common location in the tibia, femur, or the humerus. There may be epiphyseal, metaphyseal fractures. These are very specific for children with intentional injuries. These are called corner fracture or bucket handle fracture, because a very large force is required to sustain such injuries, and a child without a history of sustaining any large force trauma will usually be suspected to have a child abuse. And rib fractures also in young children have a high association with abuse, because the elastic rib cage of children prevent most of the fractures that can occur due to accidental trauma. And the fractures in these patients are mostly near the costovertebral junction with the posterior segment of the rib. Even clavicular fracture in children can also occur from the trauma of shaking the child. When these children present to us multiple fractures with a history of minimal trauma, always it raises a red flag, and requires investigation for potential child abuse. Multiple fractures when the age of the fractures is different is also pathognomic for child abuse. And when this is suspected, a skeletal survey is always indicated in these patients. Coming to burns, in 20% of the pediatric patients who present with burns, it may be a result of child abuse. Mostly it is seen in children less than 2 years. The demographic picture usually seen are the children raised by single mothers who are in foster care, and the history is mostly inconsistent with the pattern of the burn sustained. When this child present to us, the history examination, other signs of abuse are also to be looked out for. The pattern may be circumferential burns, or it can be on more than one extremity. It can be punctate or the cigarette burns, or there may be patterned burns that is also called branding, either on abnormal areas where you do not suspect burns, such as the buttocks, genitalia, or the perineum. Some uncharacteristic features which raise some doubt would be the lack of a splash or when the child has the burn, the consistent depth of the burn that you see, the large area involved, a clear demarcation of the burn or burns on the buttocks of the perineum. Children usually explore with their palms, so burns on the palms we can consider it to be mostly accidental, but burns on a dorsum of the hand of the child usually is suggestive of an abuse in these children. And in this case, the silverware in the house was actually directly matching the injury that was seen on the child. So pattern burns are mostly pathognomic of an intentional injury that was on the back. And it is also seen that second degree burns usually require a significant time of contact. So it is highly unlikely that a child would be able to maintain such contact with the substance without withdrawing quickly. So usually children with accidental burns will have first degree injuries, second degree burns are unlikely. And it would be mostly suggestive of some that was malice towards the child. And even children with flame burns may be suggestive of potential abuse by either neglect or placing the child in an unsafe environment. In this image, the child has sustained bilateral ankle and foot burns with burns to the perineum, mostly seen in children who are being toilet trained, who are not able to respond positively to the caregiver or the parent of what they require. The other mode of presentation is a thoracoabdominal injury. It is actually the second leading cause of death in children who have sustained child abuse, but it is less common. And the treatment protocol for any child with an intra-abdominal thoracoabdominal injury is the same as for non-intentional trauma. In these patients, specifically injuries to the perineum should always lead to consideration of an abuse and it should be ruled out. The most likely mode of injury seen in patients of child abuse will be penetrating, either lacerations to the rectum or the vagina. Any child with an abnormally dilated orifice, abnormal incontinence which is not consistent with the history given, any retained foreign body noted, or any chronic scars in the perineal region should always raise a suspicion of a potential child abuse. In our government, basically against child abuse, we have the Indian Child Abuse, Neglect and Child Labor Group, and also the project of Children Against Child Abuse have been brought to help fight the crime that is child abuse. And there is also a helpline also that is for children to raise the signal themselves. And coming to a few literature regarding the child abuse and the protocols against it, this is actually an article that has identified the victims of non-accidental trauma as well as the type of surgeries that they are mostly required. They have found out that mostly the children of abuse have required neurosurgical procedures such as evacuation of a hematoma, requiring a shunt, requiring aspiration of subdural hematoma, closure of the lacerations on the scalp, placement of gastrostomy tube due to intra-abdominal injury, repair of a vaginal laceration, and even thoracotomy for esophageal perforation and laparotomy for repair of a duodenal perforation, as well as drainage of biliary leak. These are all the types of injuries that are presented to this center. Coming to the guidelines that have been provided for clinicians, basically the WHO has given a clinical handbook for respond to any child of maltreatment. I have just included the major points from that. They have provided a physical exam checklist for any child when you are suspecting a child abuse. To be documented the general appearance, the emotional state of the child, the height and weight, and the head circumference if the child is of a young age. The skin should be examined for any bruises, any bite marks, abrasions, lacerations, and they should all be described. The oral cavity should be looked for any injury or any suspected infection, any bruising or any dental trauma. The fontanelle of the infant should be checked for, and they should be palpated for any fracture or hematoma, and the eye injury should be looked out for, even bruising in the ears as well. And patches of alopecia is also suspected in a neglected infant or an abused child, and retinal hemorrhage should be ruled out by fundoscopy examination. Neck may have features of any bruising, they may be there, ligature or choke marks may be there. There may be costochondral tenderness. In females, the development of breast should be documented. Abdomen, back should be looked for bruising as well as tenderness. Extremities also for tenderness, any deformities. The mental state of the child as well as the developmental stage of the child should be documented. In case of genitoanal examination, males and females, the Tanner stage should be documented. If there's any inguinal lymphadenopathy, if there's any abnormal secretions, then or any grab marks or any bite marks, any heel scars, any features of STI, or unusual findings such as pubic lice or rash in a very young child, or presence of any discharge and the discharge source should be located. In specific to females, to be looked out for are any abnormal inflammation or edema of the urethral or the periurethral tissue, or any abnormal change in the size of the clitoris, or any lesions in the labia. If there's any distortion in the shape of the hymen, any tears or transections or any bleed, any abrasions or bruising, and again the same thing should be noticed for the rest of the examination also. And if there's any inflammation, bleeding, discharge, or any signs of trauma that are noted. In males, they may have abnormal bite marks on the penis. They may be edemas, hemorrhages, lacerations, or any dried secretions which are not usually present. STI lesions as well as the Tanner staging, and if testes should be documented if it is descended or undescended, any signs of atrophy or any abnormal difference in the tissue on palpation, and if there's any abnormal features on a sexually transmitted infection. The other strategy that has been brought forward for against child abuse is by the WHO, CDC, and the World Bank and UNICEF, that is INSPIRE. These are 7 strategies for ending violence against children. INSPIRE stands for implementation and enforcement of the laws. The norms and values should be changed. Provision of a safe environment, the support by the parent and the caregiver, the strengthening by the income, the response and support services, as well as life skills and education provided. They say that violence against children can occur from a lot of issues. That can be mental health problems that can occur in the child or the parent themselves, or they can be due to chronic diseases in the parents themselves. It can be due to communicable diseases and risk behaviors among the peers or the parents, and then the injuries themselves that the child sustains. So all this requires provision of appropriate justice for the children, education and social welfare, planning by the government, and provision of financial labor, as well as education and life skills to the children and to the parents themselves. They also noted that according to the age, the type of violence faced by the child was also affected. In less than 5 years, it was mostly abuse and maltreatment, but as the child grows up, their child is also uh, prone to a lot of bullying or youth violence, but sexual violence and emotional violence and witnessing of violence was seen in all age groups. Irrespective of the age group, it was seen that children were prone to this. So they brought together a social ecological model for understanding, that is at the society level, community level, relationship as well as the individual. They said that the economic, gender inequality as well policies and the management of poverty as well as legal norms and cultural norms should be taken care of. And the child should be in a place with a proper employment. There should be low crime level. The institutional policies should be appropriate, and the victim care services available should be good. The parenting practices should be changed, and the domestic environment the child is raised should be healthy, and early and forced marriages should not be there, and the socioeconomic status should be enhanced, improved, as well as the peers among which the child is there. The peers strengthening should also be there, as well as the victims of the child maltreatment should get access to proper management, and any history of any violent behavior, abuse, or any psychological disorder should be taken care of in these children. This is an algorithm that has been provided for any screening and management guideline in any child that is a suspected case of abuse. Red flag histories at the presentation will be if there is no history of any trauma, but the child is presented with an injury, or if it is an inconsistent history, or if there is a change in the history and it is an unwitnessed injury, if there is delay in seeking care after the child has sustained the injury, if there is any history of any prior emergency visit, there is a history of domestic violence in the home, there are chronic medical conditions in the child, and the child is a preterm low birth weight triangular. Some physical findings that are red flags include the, as previously mentioned already, the poor developmental, physical and emotional development, and bruise in any non-exploratory location, and bruises, marks, or scars that are patterned. That suggests the child has been injured with a specific object. And on X-ray, it might be noted that the child may have metaphyseal fractures, which as mentioned previously are quite specific, rib fractures in the posterior area, and any non-ambulatory infant with a fracture, or any undiagnosed healing fracture or neuroimaging in the absence of any skull fracture. And all this in children who are young age, or less than 1 or 2 years of age. A routine laboratory workup such as the hematocrit, the PTINR, and the metabolic panel and lipase, if there is any suspicion of abdominal injury is done, and urine analysis is done. If fractures are present, the test pertaining to it should be done. Then coming to radiological evaluation, a skeletal survey is always indicated if there is any suspicion, and a non-contrast CT is always useful to rule out any head injuries, which may be visualized. And then if there is any abdominal complaint or abdominal injury suspected, an abdominal CT is indicated. The management for is the same as the management for any non-intentional trauma. Then the child has to be this has to be reported to the pertaining authorities, as well as pediatric surgical evaluation is done for the head to evaluation of any trauma. The other team that may be involved are the neurosurgical team, the ophthalmological team. A neuropsychological evaluation of the child should be done, and if the all the criteria are met, and if it is there is any suspicion that the child has sustained some non intentional intentional trauma, then the members that would it was usually a multidisciplinary approach. It may include the emergency physician, the physicians, and the surgeons who are pertaining to the injuries that the child has sustained, as well as government employed social workers should be taken, and the child may be admitted in the ward or the ICU as per the clinical status of the child. And then the child is subsequently reviewed accordingly. And prior to discharge, also these same multidisciplinary members should also be involved in the patient care, and a strict follow-up should also be done to ensure that in the future the child does not sustain the same injury or is inflicted to the same injury. And there is always a point of being direct and objective, and the parent should be always informed that it is also a part of the diagnostic consideration that the parents are also kept under suspicion, and the focus should be on the child, and the child also should not be interrogated at any point of time, and that there should also be a psychological evaluation at that time.
So, right, we discussed about the birth and all. So what are the